Hi, Terry QT with DiepCFoundation. I'm here with Dr. Daniel Liu today with Cancer Treatment Centers of America. And Dr. Liu has done a great deal of microsurgery as it relates to lymphedema. And so he's going to talk to us specifically about that today, lymphedema surgery as it relates to DIEP flap. Welcome, Dr. Liu.
Great. Thank you very much for having me, Terry. There is a lot to talk about when it comes to how lymphedema affects our breast cancer patients. Up to about 30% of breast cancer patients have to deal with lymphedema at some point after their treatment, and usually it has to do with the removal of lymph nodes from the axilla as part of an axillary lymph node dissection, and the risk goes up if it's combined with postoperative or adjuvant radiation therapy to both the breast and the axilla.
Right.
When it comes to a conversation about breast reconstruction options, we typically recommend autologous reconstruction in patients who will receive radiation. And in my practice, I prefer to offer that operation after the radiation has been delivered, at which point we usually have some inkling or some set of symptoms that may be experienced by women with early lymphedema. In those women, I would offer a combined surgical approach where we treat the lymphedema in addition to taking care of the breast reconstruction. So we call that a total breast anatomic reconstruction, which includes a typical DIEP flap or similar lower abdominal free flap combined with the lymph node transfer using expendable lymph nodes from the lower abdomen or the upper groin.
Okay.
So we find that by combining those two treatments, we can both take care of breast reconstruction by offering the most natural type of reconstruction we have available and potentially treating or limiting the progression of early lymphedema symptoms.
So when you're treating the lymphedema as well, is the recovery any different when it's added into the, if that makes sense?
Sure, and that's a great question. I usually tell patients that if we're doing a free tissue transfer anyway, using the DIEP flap, adding the lymph node transfer portion may increase the operative time by 1 or 2 hours, but overall the postoperative recovery is pretty much the same. There is minimal added risk of donor site morbidity, specifically with fluid collections or seromas at the lower abdomen, and a theoretical risk of creating new lymphedema in the leg, but we have been able to avoid that using newer techniques we call reverse lymphatic mapping to avoid taking unnecessary lymph nodes.
All right. And how about physical therapy post DIEP flap with lymphatic surgery?
I think it's important to understand that physical therapy remains and will always remain the mainstay of treatment for lymphedema. And I encourage all my patients to meet with a physical therapist 4 weeks after a mastectomy with or without reconstruction. And then being followed by a physical therapist enables us to identify the early symptoms of lymphedema, both with physical measurements, circumference measurements, as well as an LDEX test, which is a bioimpedance test that can detect early differences in fluid content within one extremity versus the other, even in the absence of physical swelling symptoms. So that's one way that women may know they are at risk for developing lymphedema. Continuing afterwards, following surgery, it is definitely crucial to continue whatever therapy a woman has been receiving for lymphedema, including compression garments, physical wrapping, and other therapies like lymphatic pumps.
Right. And how about diet, just to throw that into the mix? Anything, I hear people talk about less salt to help with anything to do with diet at all, or?
So maybe in the extremes. So for people in general who have more fluid accumulation because of a high salt diet, then changing lifestyle modifications, including lowering the salt content of their diet, may help overall decrease the fluid content. But in general, there are not many specific changes that we recommend to a patient's diet. I will say that obesity is a significant risk factor for developing lymphedema and for treating it. So Weight loss is often a component of breast reconstruction as well as lymphedema therapy that we recommend to all of our patients who are at risk.
Okay, well, that was very comprehensive. Thank you so much for your time today.
Great, thank you, Terry.
All right, bye.